Well,
Hi.
good morning,
Thank
everyone.
you. Thank you.
Thank you for inviting me to speak. Really, it's really nice being here. Um, Thank you for some really interesting talks, Nilofer and Subal. I think I've always learned more from this and from working with all of you, and it's always a pleasure because there's just so much to learn, and things are just getting better and better each year. We all work together. I'm Dr. Rathy Kirke. I'm a consultant radiologist. I'm based at the Royal Derby Hospital. I have been working with the team for quite a few years now, and I'm going to be talking to you about how we image endometriosis. I'm going to give you a little bit of an overview. Let me share my screen on what endometriosis looks like, both on CT and on MRI and on ultrasound. CT, obviously, I'm not going to go into CT because that's something we've just started working on more recently. So
Could you go on a slideshow?
I have, is that, there you go.
Okay, good.
So we've heard quite a bit about what endometriosis is, what the symptoms are, how they present. We've heard a lot about how the diagnosis is delayed. So how do we image endometriosis? So So we all know what's endometriosis. It's a fairly complex inflammatory disease. You've got glands and stroma outside the uterus, up to 15% of women at the reproductive age. We've talked about the clinical signs and symptoms, and we've also talked about the fact that a lot of these women get a fairly delayed diagnoses. In fact, what's interesting is now we are finding women who are being diagnosed in the postmenopausal years when they all start on HRT and the process flares up. Sometimes they get, that's when we sometimes seem to be diagnosing these women. So it's definitely an underdiagnosed condition. So in this talk, I'm going to talk to you about where endometriosis can be present, predominantly in the pelvis. I'm not going to touch on the chest and the abdomen because I think that's going to be quite an extensive talk, and I think that's still something we're still in the learning process of on how to diagnose extrapelvic endometriosis with imaging. We obviously do it really well with laparoscopy. I'm going to touch on ultrasound technique, what ultrasound looks like, and what MR looks like in endometriosis. So when you look at the pelvis, you can get endometriosis anywhere. You can get it on the anterior abdominal wall. You can get it on the round ligaments. Obviously, the commonest site we say is always on the ovaries, where you have the classical chocolate cysts. You can get endometriosis in the pouch of Douglas at the back, between in the the rectouterine, and also the pouch between the uterus and the bladder. So effectively, you can get endometriosis anywhere. On the sagittal view, again, you can see I'm going to use a laser pointer. So you can see how endometriosis here between the bladder and the uterus, commonly seen along the posterior aspect of the uterus. Now, this is one area which is really common to see endometriosis on, but we're still learning on how to image it the best way we can. The rectovaginal septum and also on the surface of pelvic sigmoid. So it can effectively be seen anywhere. So let's talk about ultrasound first. Now, ultrasound is a good initial test because when patients present with symptoms of endometriosis, the dyspareunia, the heavy periods, the pain, most patients should have an ultrasound. It's a really good first line test because it gives you a really good overview of what the anatomy of the pelvis is like, where the uterus is, where is it oriented, is it anteverted, is it retroverted, what's really going on in the pelvis. At Derby, we do a fairly basic ultrasound. More recently, when I was at a talk a few months ago, but when talking to some American authors, when they do an endometriosis scan, they've gone one step further. They start treating patients with rectal enemas and give them a low residue diet before they do the ultrasound, because there are techniques developing now to look at bowel very closely in ultrasound, but these do take a lot of time and a lot of expertise. It's not something we do currently because pretty much we have MRI. So with ultrasound, we look beyond the uterus and the ovaries. It's not just looking at the uterus and ovaries, which obviously a first step, look at the uterus, look at the ovaries, and then you've got to go beyond those. You need someone who's really experienced with ultrasound, because when somebody learns to do ultrasound, they obviously learn to look at the uterus, the endometrium, the cervix, the ovaries, where everything is, and then they start moving on to the dynamic assessment. The other problem we have with ultrasound is people are getting larger. So the larger they are, the more intra-abdominal fat, the harder it is to make that assessment. We need time. In our pressured NHS lists, where we've got 15 to 20 minute sometimes just 15-minute appointments to do ultrasounds. It's just not possible to take that time, get the patient nice and relaxed and scan through the pelvis. You need at least half an hour to do these scans properly. And if the patient's never had their kidneys looked at before, it's always worth putting a probe and making sure the kidneys are not hydronephrotic. So when we do pelvic ultrasound, the IDEA consensus group has recommended that we do a nice systematic analysis, a nice 4-step process. So we start off with, we talk to the patient, make sure they don't have any latex allergies, explain what you're doing. We have a chaperone in the rooms most of the time. You evaluate the uterus like you normally would. You evaluate the endometrium, the myometrium, the cervix, and then you look at the adnexa on either side, look at the tube. And then you start doing a fairly dedicated search for deep endometriosis. The soft signs like the phonoceal tenderness, that always works. And then you also do the sliding signs. Now, with ultrasound, what I really like about ultrasound personally is you have a really good, you can do a really dynamic assessment with ultrasound. You can move the probe into the phonoces, into the anterior compartment. You can put your hand on the patient's belly, move it around, and just see how the pelvis moves. You get a really good feel, just like what the gynecologists do. Someone recently told me that when you scan a patient for endometriosis, think like a gynecologist. I thought that was too complicated for me. I thought, no, thank you. I'm just a simple radiologist. But I think that it made sense because that's when you do with an internal exam. They move the uterus, they're feeling the posterior space, the anterior space. That's the sort of feel you try and get with the ultrasound. We look at the anterior compartment, look at it, and just get a feel of how is that uterus? Is it moving? Are the pelvic structures sliding around, or if is everything fairly rigid? Now, you only get that feel if you've done many, many ultrasound scans, and you have to do it on every patient. So you get a feel of what a normal pelvis is like, what a normal pelvis moves like when you do an ultrasound. And then when something is stuck, you get a feel of what being stuck looks like. So in the anterior compartment, you've got the space between the bladder and the uterus. Now, you can get endometriosis here. When I do the ultrasound, we try and move the uterus and just look at a bit of sliding between those two tissue planes. I want to see the uterus and the bladder moving separately. I want to see a little bit of movement, or in fact, the more the movement, the better. I just want to see structures sliding around with each other. When we assess the posterior compartment, it's the same. I think, and posterior compartment assessment is probably more difficult. This part is what I always look at, the rectovaginal septum. I want to see movement of the uterus, the posterior part relative to the sigmoid and the rectum. I want to see that moving around. You do see deep pelvic endometriosis here on ultrasound if you look for it. It's really a non-specific way of, it's a dark area, but the movement is what really helps. And that's what the IDEA recommend. But you need time, you need the patient to be relaxed, you need a chaperone in the room, and you need to explain, you're going to feel a lot of pressure and movement. If it's so, please let me know. You need to talk to your patients and make sure they're relaxed and they know what you're doing. And this takes time. So if you look at a classical endometrioma on the ovary, that is what we call a chocolate cyst. This is what a chocolate cyst looks like. It's a nice rounded area with lots of low density gray echoes within. This is just a classical endometrioma, which we can see on ovaries. Now, when we see endometriomas, they can be on ovaries lying in a normal location, or the ovaries might be pulled into the pouch of Douglas posteriorly. So this is the uterus here. You've got endometriomas on both sides, and the ovaries have been pulled backwards into the pouch of Douglas, and they're stuck to the back of the uterus. That's what ultrasound can, and this is the classical kissing ovary sign. Now, the other thing that's associated with the spectrum of endometriosis is adenomyosis. So you've got a fairly asymmetric myometrium on either side of the endometrial stripe. You've got a very, very thickened posterior junctional zone. People talk about a classical Venetian blind-like effect when you get lots of shadowing in the posterior part of wherever the adenomyosis is. Sometimes you can just see nice, bright echogenic glands. I think it's a difficult diagnosis to make on ultrasound. You do need to really get a feel of what adenomyosis looks like. There have been times when you can get it confused with fibroids. I think it's difficult, but if you see adenomyosis, you sometimes think, can this patient have endometriosis? So again, a good first test, being ultrasound's a good first test. So in the pouch of Douglas, when you get the probe into the vaginal area, this is what I always tend to look for. Is there a nice, bright, fatty space between the posterior uterus and the sigmoid, or have you got dark dark tissue which just stops the uterus from sliding with the sigmoid. Now that gives you an idea that there is pouch of Douglas disease and it's infiltrating. What it can't give you an idea of is how much it's actually infiltrating bowel, unless you do the bowel preparation techniques, which are slowly coming out in other parts of the world, which have been, sorry, not, they are being done in other parts of the world where MRI is not as freely available. But that's something that is a bit more difficult, but you can definitely detect deep pelvic disease. If you look for it, you can detect it, but you've got to look for it. If you go straight cervix, right, quick cervix, I'm happy with the cervix into the endometrium. Let's look at that. Let's look at the ovaries. And then you've got to start looking for the deeper, the posterior signs, the signs in the pouch of Douglas. I'm going to talk about MR imaging of endometriosis. Now, personally, I think ultrasound's a very, very good first test. But as we progress and as we work with the Endometriosis Center, as we have our endometriosis meetings, and we start looking at patients and getting that feedback, I personally think the MRI adds a lot to endometriosis imaging because it really maps out a lot of the disease. MRI isn't perfect. There's no perfect imaging technique. We can get situations where I report an MRI as being completely normal, and the prof comes back to me and says, well, we found endometriosis everywhere. Thanks, prof. That makes me feel really good. But yes, it's yes, but so I know it's not perfect, and I think the endometriosis team, Sybil, prof, they all realize that. But
it's getting much better.
Oh, thank you, prof. That's used to.
Oh, Rathy.
Yes, but it's a really it's a good I think it's a good test. And the thing is, there's a learning curve with MRI. I find it's a learning curve. For 5-6 years ago, I didn't see things, and now I'm seeing them because we have evolved into getting better and better. There are four of us, four gynae radiologists at UHDB, of my colleagues, and we all work together and put our heads together and say, we are getting better at looking at MRI. Now, why MRI? I think it's because you've got an excellent soft tissue resolution. The information is there. You don't have to hunt for the information. It's already there. It's presented to you in nice pictures. You just have to look for it. It's not dependent on the operator. So once the patient can go into an MR scanner and lie in an MR scanner fairly still for a certain amount of time, we get the images we need. Pacemakers used to be a contraindication, not anymore. We have, pacemaker MRI scan. People with pacemakers are now having MRI scans. There is a waiting list across the country, obviously, but they still can have MRI. So MRI isn't a huge contraindication anymore. It's got a very high sensitivity for deep infiltrative endometriosis. We do see deep disease. We see how deep it's going into the bowel. And we also look, you can also assess it in slightly uncommon locations. There is a lot of work being done on looking at it in the subdiaphragmatic areas on the surface of the liver. We're not quite there yet with it, but it's hopefully coming in the future. So what is our standard MRI technique? We give them, all our patients they have an empty bladder because the bladder tends to fill as they go through that 45-minute MRI scan. We don't want them getting too uncomfortable on the scanner, so we do ask them to empty their bladder. They all get Buscopan, so to stop the peristalsis of the small bowel, which gives us better pictures and also helps us assess bowel in the pelvis. We always have a fat saturation sequence where all the fat becomes black, so any blood stands out quite well. We've got a three-plane, that is your axial, your coronal, your sagittal. We do three planes. If contrast is needed, we do give contrast. Now, we don't give contrast to everybody as a routine because there's been a lot of work done, not even work done, there's been a lot of information coming out recently about the deposition of gadolinium in the brain, and many of our patients are fairly young women, so we really don't want to take that risk. I mean, even if it's a small amount, but we tend not to give gadolinium to young patients if we can, and we always have sequences that include the kidneys, just get a feel of what the renal parenchyma looks like. So on MRI, this is what adenomyosis looks like. So here you've got a uterus that's fairly upright. It's slightly retroflexed, and you can see the pouch, the lovely pouch of Douglas. It's just almost obliterated. There's not much tissue there. It's sort of sticking back. This is the adenomyosis. You've got dark areas with small cystic spaces. You've got a thin anterior myometrium, a fairly thickened posterior myometrium with all these little cystic spaces in the dark area. That's what adenomyosis looks like on MRI. it's fairly obvious to say this is it. You're 100% specific with it. It's very sensitive, and you've got a lovely endometrioma sitting in the right next to the uterus. A few little bands of adhesions. This is definitely stuck to the uterus. You can see there's absolutely no fat between the. This is fat. The white bit's fat. There's no fat between the uterus and the ovary. This is going to be tethered to the posterior uterus. And we will talk about endometriomas, but they show the lovely, they show shades of gray, or T2 shading as we call it. You've got dark gray, lighter gray, and then a much lighter gray. So if you see T2 shading in a cystic lesion in the pelvis, that is going to be an endometrioma until proven otherwise. Now, endometriosis does cause a lot of adhesions. It blocks tubes. It causes indirect signs and symptoms. So you can get hydrosalpinx. You can see this nice little tube. Now, I think hydrosalpinx is quite difficult to confirm on ultrasound because they can be called adnexal cysts, they can be called vessels. We've seen the thing, but on MRI, you see that is a hydrosalpinx. There's nothing else it can be. You can see blood in it, and it's a hematosalpinx. You can see it around the broad ligaments. The anatomy is all there for you to look at. So if you look at the disease in the posterior pelvis and the adhesions, now you've got if you think about this lady having an ultrasound, you've got the vaginal probe just up to that level over there. So that's going to fan out all this area, and you're going to be able to look at this bit really, really well, the rectovaginal septum with an ultrasound. But if you look at the dynamic assessment, this is actually quite high up. This is between the sigmoid and the posterior aspect of the uterus. You can see this big band. You shouldn't see bands. You should see fat going all the way along the uterus with no dark bits in between. If you see these dark bits here, that is a big adhesive band between the uterus. That is a band, that's deep pelvic endometriosis. So you see the entire layer of mesorectal fascia thickened, fibrosed, and you see endometriosis starting to infiltrate that sigmoid wall, starting to pull it anteriorly, starting to push the uterus posteriorly. Those are all the adhesive infiltrative bands of endometriosis that sort of develop at every cycle, every time these glands reactivate. Looking at ovarian endometriomas on MRI, so that's the adhesions. So ovarian endometrioma, so this is a T1 weighted sequence where you see bright bits. Now, we know blood is bright. A dermoid can also be bright. Any fat and blood are both bright on T1 imaging. So we do a fat suppression sequence where we make the fat dark, and if it still stays bright, we know it's blood. So it's usually blood is bright on T1 weighted imaging, and you've got dark on T2, or you can get shades of gray. The darker it is, the more hemosiderin there is in the ovary, and that's what ovarian endometriomas look like on MRI. It's a cut and dye diagnosis. There's no two ways about it. You've got another endometrioma here that's got more fresh blood in it, so then it tends to be you've got a bright rim and you've got a little bit of darker blood in there. That's probably a hemorrhagic cyst, which is also associated with the spectrum. You can see the IUD in the uterus, and then you can see the uterus just pushed back. So I'm going to talk about rectal plaques. Now, what is a rectal plaque? You've got this big bit of endometriosis infiltrating the entire rectum. Now, if you look at this particular slide, you can see this area here, which is almost like a little tree cap or a mushroom cap that's infiltrating the wall. Now, that little black thing is the lumen of the large bowel. The lumen's collapsed over here, and I know it's not infiltrating the lumen, but this is going quite deep. This is over a couple of centimeters. It's going into the rectosigmoid wall. And if we see something like that, we do know that this is going to need our colorectal surgeons to be involved when this patient has her surgery. Again, there's lots of pelvic adhesions, everything's sort of stuck down. This, and you can look at this, you can't really see with ultrasound. You can tell that the things are stuck down with ultrasound, and you can tell that there are adhesions. But what our colleagues like to know is how deep are these plaques going into the wall? Is this just something that they can shave off? Or do they need to actually resect and then do a primary bowel anastomosis? Now, that information is really it's available on MRI, and that's why we tend to really favor MRI for looking for deep pelvic disease. The other thing we're seeing a large increase of diagnosis is scar endometriosis. So ladies who've had cesarean sections, they come back over a period of time complaining of pain, swelling in the region of their scar, particularly at the time of their periods. And it can evolve over a period of many years to become quite extensive, quite ugly, quite nasty looking, as you can see here. On these T1 weighted images, you've got all these cystic spaces in the anterior abdominal wall filled with blood. And on the T2 weighted images, you can see how much scarring is there around the cesarean section scar. Now, this is something, again, we can diagnose with MRI. We can diagnose this with ultrasound, but again, the extent and mapping it all out it's quite good with MRI. And again, this is something you can say, this is exactly what it is. It's not nice, but we are seeing a lot of scar endometriosis. As we follow the sigmoid, you can actually see endometriomas on the surface of the sigmoid on this scan. So the sigmoid's coming. This is a big endometrioma from an ovary. The sigmoid follows the ovary all the way around, but you've got endometriotic deposits on the sigmoid. This is not just Web plaque infiltrating sigmoid. This is actually endometriomas on the sigmoid. We're seeing more and more of that. We look for it on MRI, and that's what we tend to see. So again, something that we tend to look out for. Again, MRI is beautiful looking at these little plaques. So this is something we call the mushroom cap sign, where there's a huge, it's almost an entire little tree head or an entire mushroom that's developed over the sigmoid, and it's pulled everything down on the front of the uterus. This uterus is actually retroflexed. You've got these adhesions in the pouch here. And this mushroom cap is just stuck to the top. So this is going to be, I think this may cause a bit of a challenge for our colleagues when they trach it out. But again, MRI gives them an idea of what they need, how to plan their list, which expertise they need in the room when they're tackling something like this. We had a patient who had a cystic boggy swelling behind the rectum and behind the sigmoid. And again, we needed an MRI to figure out what this was. This was a presacral endometrium. Again, an example saying that endometriosis can occur anywhere in the pelvis, in unusual places, in unusual areas. So this is something that, again, we managed to diagnose on MRI, and our team managed to go in, plan their approach, and then tackle this. So looking for the most subtle signs of endometriosis on MRI, you've got broad ligament involvement. You see this little nodular irregular scarring. Normally, we just like to see nice clean fat in the pelvis, ovaries, uterus, pelvic bowel, a bit of fluid, great, all looking good. But here we see this irregular scarring, spiculate areas. This is what broad ligament nodules along the broad ligaments looks like on MRI. You've got adhesions between the uterus and the bit of the anterior a part of the bowel, the peritoneal reflections. So we see this quite well on MRI. You look for it, we tend to see it. So on the next slide, I'm going to show you how the anterior and the posterior compartment involvement is seen. So again, there's a loss of that lovely fat plane, dark areas between the posterior cervix and the sigmoid. That's your posterior disease. This I can tell you is not infiltrating the bowel. It's just a superficial adhesion. So this can be probably trimmed off quite quickly. Now here you've completely lost the fat plane between the posterior bladder. You can see it kind of hoiked up and stuck to the anterior aspect of the uterus. So again, this helps them plan. They need to move that bit of colon out of the way, go in there, take all those adhesions out. So MRI again does help you really plan your surgery. Now, we're seeing more and more interesting involvement with endometriosis, are unfortunate sometimes, but it's interesting. And bladder involvement is something I'm going to talk to you about. Earlier this year, we had a lady who presented with pain after hysteroscopy. So she had an ultrasound which showed on the transabdominal views a little sort of an irregular area between the uterus and the bladder. Taken really well, beautiful images, but really difficult to interpret, unsure what this could be. On the transvaginal ultrasound, again, a very just sort of a grayish, hypoechoic, not completely as dark as fluid, but between the uterus and the bladder, we saw this irregular grayish, sort of intermediate echo area, which was really non-specific. It was avascular, very, very difficult. This was called a hematoma. And then this lady continued to have pain, and then there was a concern about bladder and ureteric injury, so she ended up having a CT. And again, between the uterus and the bladder on CT, you've got this little high density area, which again was unusual. It was in an unusual place because I have never seen an anterior uterine perforation. We've seen if we can get a posterior uterine perforation because of the uterus, especially when putting brachytherapy applicators, but I've never actually seen an anterior uterine perforation just because of the way the uterus moves. So this was a bit unusual. She was still in a lot of pain, so we just, we need to get her through the MR scanner. And on the MRI, we saw this dark area sitting at the back of the bladder, separated the uterus and the bowel, definitely not hematoma, irregular dark areas with tiny white cystic spaces. This was bladder endometriosis. We could confirm that on MRI. It was a bit difficult to confirm on ultrasound on CT, but with MRI, we knew this was just lady had endometriosis on her bladder wall, which was infiltrating the bladder wall with each cycle. So this was something that we fought for quite recently. And again, it's a bit of a learning curve for us. So I'm going to talk about cecal and terminal ileal endometriosis. Again, I must say this is one of the first cases I've seen. I've heard about it, but this is one we had a few months. I've had a few, was it last month? This patient presented with endometriosis. She apparently had an appendectomy, and on the appendectomy specimen, they found endometriosis. So she came back to us. We imaged her with MRI, and you can see that's the cecum coming in, and then that's the terminal ileum, and you've got endometriosis on the surface of the cecum, infiltrating the cecal wall, adhesions with the adjacent small bowel, and also going along the terminal ileum. I've not seen this before, cecal and terminal ileal endometriosis, but this is what it looks like. Again, with an MRI, we've been able to confirm this is what it is, so she can have her surgery planned. Same patient, you can look at this dark area on the surface of the cecum with tiny cystic spaces. I mean, that's what normal bowel looks like. That's a bit of poo in the bowel, but this is endometriosis on the surface of the cecum. Again, I don't think I didn't be able to identify this with ultrasound or on CT. This lady's had previous CTs. It's very difficult. So we look for endometriosis. We find it. I think that's what my thing was. So this was quite an interesting case for us. I'm waiting to see what happens. We'll be discussing her soon at our MDT. So I'm looking at the time. I'm going to talk to the take-home points for us. So give you a few minutes for questions. So ultrasound's a great first test. We need to look beyond the uterus and the ovaries while doing a pelvic ultrasound when you're thinking about endometriosis, the anterior compartment, the posterior compartment, the soft signs, the tenderness, the ovarian mobility, and the sliding sign, but we all need time, which I think most of us don't have. The dynamic, is the pelvis moving? Are things in the pelvis moving? That's key really with ultrasound. MRI is a really good test. I think. I mean, I don't know if I'd made it fairly obvious that MRI is definitely my favorite imaging modality for endometriosis. We all have supervised lists where we can see the images as they come off the scanner. We can, if the radiographers call us, they tell us, what do you think? And we go, right, okay, I'm not quite happy with this image, this area a bit better. So we've got that hands-on luxury, can I say, with MRI, because a lot of centers don't have supervised MRI scans, whereas we've fought really hard to maintain our supervised scans so we can see the images as they come out of the scanner. And we consider MRI for mapping. But I think the most important thing is we work really well as a team. We work well with our radiographers, our sonographers. We work well with our endometriosis surgeons. So that makes a big difference. So these are just my references. And then I'm ready to take questions. Thank you.
Thank you very much, Rathy.
Yes.
Really excellent talk, and your input into the MDT and the Endometriosis Center has been really, really valuable. And I have to say, we now, as surgeons, reviewing the MRI with Rathy and then taking the patient to theater, I think it's now really near perfect correlation, whatever the depth of invasion, what we see. And the nice thing is we share this with Rathy and she can show us the images, and we go at laparoscopy. When you put the scope and you can't see it, but when you start to dissect them. Now, this is, as Rathy said, this is crucial before planning for any complex surgery. Setup, colorectal surgeon, urology, it's really amazing, and the center wouldn't have been a center without Rathy's and her team input into this, and I hope to continue to collaborate with us. It's really been a very interesting and useful. It helps patients to a great deal. So thank you very much for beautiful demonstration of the various pathologies, although I was expecting to see something on the ureter, but maybe Subul can tell us about the ureter later. Okay, so I think we'll open the floor.
We've got a question, Prof, by a Dr. Chowdhury, saying, how do you identify endometriotic plaques in MRI which are not invasive to the adjacent organs? Anything? Dr. Kirk, Rathy.
Suitable, thank you. It says, how do you identify an MRI not invasive to adjacent organs? I think within the scan volume on, I mean, I don't think we could do this with ultrasound. I'll be honest with you. I think this is something that we do with MRI. So we do a technique, we do a T1, T2 whole pelvis from the iliac sort of crest down to the perineum. So we do a whole mapping of the pelvis. We look at those images when we come out and see what doesn't look right. And I think what we do is, as I said, we've got the luxury of looking at the images as they come out of the scanner. So we try and do our best. I'll be honest with you. We don't always pick it up because some small plaques you wouldn't see on MRI, you'd see them on laparoscopy. But when, as I showed you, the cecal plaque, we are looking for it. We're not just looking for Porter Douglas disease, chocolate cysts on ovaries. We're actually looking through the serosa of the small bowel and the pelvis. We're looking at all the large bowel image. We're looking at it quite closely, and that's probably we try and do our best, I guess.